Welcome everyone. Thank you for joining us for today's webinar titled What You Need to Know, Diabetic Ketoacidosis and Hyperglycemic Hyperosmolar State. This webinar is supported by the Sanofi Lexicon Alliance. The presentation is educational in nature and contains no promotional or product information. Continuing education credit is not available for this activity. If you would like to ask a question during the presentation, you can type it into the Q&A box on your screen at any time, and we'll answer as many questions as possible during the Q&A session at the end. Our presenter today is Carla Cox, a diabetes educator and dietitian at Mountain Vista Medicine in South Jordan, Utah. Carla will review the physiological response to severe hyperglycemia and the most frequent causes and consequences. She'll also review the education principles that you can share with people with diabetes to promote prevention of hyperglycemia, as well as the basics to increase awareness of the challenges of treating the serious outcomes of severe hyperglycemia. So now I will turn it over to Carla to begin.
Thank you. It's great to be here, and thank you all for joining us. So our learning objectives today are that at the end of this session, you should be able to describe the basic physiology and risks associated with diabetic ketoacidosis, or DKA, and hyperglycemic hyperosmolar state, or HHS. You should be able to teach the principles of DKA and HHS prevention to our patients with type 1 diabetes and type 2 diabetes, and you should be able to cite the basic treatment strategies for mild, moderate, and severe DKA and HHS. So the physiology behind DKA. DKA is a cascade of events which starts with insufficient insulin for the present condition. Severe insulin deficiency leads to an increase in the breakdown of hepatic triglycerides to glycerol and free fatty acids. In the liver, free fatty acids are oxidized to ketone bodies stimulated by glucagon. Suppression of enzymes and rate-limiting steps results in an acceleration of ketone bodies, and ketone bodies are strong acids which results in metabolic acidosis. Onset can occur rapidly in persons without basal insulin, for example, an interruption in insulin delivery from an insulin pump, for example, overnight if the cannula becomes dislodged during the night, or it may take 1 or 2 days to occur in persons generally who are not providing adequate bolus insulin to cover the present conditions, whether it's ignoring carbohydrate intake, which unfortunately often happens in our adolescence, or during an illness. The physiology behind HHS is similar in that it is a cascade of events which starts with insufficient insulin, once again, for the present condition. In contrast to DKA, persons with HHS have a higher concentration of insulin, lower concentrations of free fatty acids, cortisol, growth hormone, and glucagon. It's generally slower onset over several days, and more severe hyperglycemia leading to dehydration, elevated plasma osmolality, and impaired levels of consciousness. Symptoms of encephalopathy are generally present when serum sodium levels exceed 160 millimoles per liter, plus osmolality is greater than 220 millimoles per kilogram. Some persons with HHS present with elevated ketones, less than 3 urine or blood beta-hydroxybutyrate millimoles per liter, which are lower than those diagnosed with DKA, which is generally greater than 3 millimoles per liter. So we're going to start discussing a DKA first. And diabetic ketoacidosis can be defined. It is characterized by increased ketones, metabolic acidosis, and uncontrolled hyperglycemia. You can see the chart here where it looks at where are normal values and where is DKA normally diagnosed. Now I do have a small asterisk beside this statement because serum glucose fasting is usually over 250, but as some of you may have heard, recently euglycemic DKA has been described, particularly as it relates to SGLT2s, and we'll discuss that in a minute. So the pH is generally less than 7.3. It can be severely reduced to less than 7. Bicarbonate less than 18 millimoles per liter. elevated serum ketones, which are positive and generally on a blood ketone greater than 3 millimoles per liter. Dehydration is generally judged clinically with poor skin turgor, dry mucous membranes as well. Generally, when we think about DKA, we consider it as a result of severe hyperglycemia over several hours to days. However, recently, euglycemic DKA has been described and can be linked to the use of SGLT2 medication in persons with type 1 diabetes. Other potential causes of euglycemic DKA include restricted carbohydrate intake, inadequate hydration, and a degree of insulin intake in the presence of underlying infection and acute pancreatitis. There are stages, generally, as many of you know, of DKA going from mild to severe, and those are noted in this chart. This table describes the laboratory measures that indicate the increasing severity of DKA. A physical evaluation and constant monitoring is required for each individual patient with severe DKA. Individuals should be evaluated and cared for in a hospitalized setting with staff that is knowledgeable in regards to the treatment of DKA. If they are not knowledgeable, they should have constant telephone contact with a regional hospital or area where they are familiar with treatment of DKA. The incidence of DKA in adults in the United States, a review of the literature from 2009 to 2016 suggests a rate of DKA between 0 to 100 events per 1,000 adults with type 1 diabetes within the last 3 to 12 months. In one study, 4.8% of the participants reported one or more DKA events requiring hospitalization during a previous 12-month period. Approximately 145,000 cases are diagnosed yearly. This data is based on information obtained through the Type 1 Diabetes Exchange Clinic Registry, and information gathered reflects a self-selected group of participants that agree to use their data for research. Startling, the average cost for managing DKA is $17,500 per episode, and the total annual cost in the United States is greater than $2.4 billion. Why does it happen? Generally, it is caused by a lack of sufficient insulin due to 1, a new diagnosis of type 1 diabetes, 2, increased insulin needs in time of physiological stress such as infections, 3, poor management choices, for example, neglecting to deliver correctional insulin or insulin for food, or insulin restrictions such as in a goal for intentional weight loss. Discontinuation of insulin pump delivery due to a dislodged cannula at the insulin delivery site is also possible, but has recently been recognized as not as common a cause of DKA as previously thought. Other than newly diagnosed diabetes, all other causes of DKA are preventable. This provides a very important role for the diabetes educator to teach and reinforce management skills that will help to eliminate hospital admissions for DKA. The incidence is higher in certain physiological stressors, such as the CVA, MI, Cushing's disease, trauma, either physical or emotional, and pancreatitis. Also in those with a history of migration, those of lower socioeconomic status, and persons with higher mean hemoglobin A1C. Although there are certain population groups that are at higher risk, all persons with type 1 in the right situation are at risk for developing DKA and should be educated on signs, symptoms, and the importance of calling the diabetes team for treatment recommendations. Persons taking some prescription medications such as antipsychotics, corticosteroids, and thiazide diuretics are also at higher risk. Persons using illicit drugs such as cocaine, persons consuming large volumes of alcohol, and women, particularly teens, in an effort to lose weight, often called diabulimia. Diabulimia is a term used to describe persons who restrict their intake in an effort to lose weight. It is estimated that up to 20% of women with type 1 diabetes may have this disorder, which can lead to DKA. Treatment requires a multidisciplinary team, including a mental health professional. Symptoms of DKA include polyuria with polydipsia, obviously due to the severe hyperglycemia usually noted, weight loss, fatigue, dyspepsia, vomiting, preceding febrile illness, abdominal pain, and polyphagia. Symptoms occur after relatively prolonged time with elevated glucose values. Glucose monitoring and adequate correctional insulin is key to preventing even the symptoms associated with DKA as outlined above. A new DKA challenge, type 1 diabetes and SGLT2 inhibitors. So approximately 20% of adults with type 1 diabetes achieve the target of A1C of less than 7%, a small number. This contributes to the search for alternative means of lowering overall glucose. SGLT2 inhibitors have demonstrated moderate reductions in A1C, reduction in glucose variability, reduction in total insulin dose, blood pressure, and body weight. This medication is not FDA approved for persons with type 1 diabetes at this time, and I will add that on July 15, the FDA denied approval for Farxiga, an SGLT2 inhibitor for persons with type 1 diabetes. In an effort to enhance the management of type 1 diabetes, SGLT1 and 2 are being increasingly used off-label. Several are presently under FDA review, and as mentioned, one of them was just denied acceptability by FDA. A dose-dependent increase in the absolute risk of DKA has been reported with the SGLT2. A recent study suggests a 5 to 17-fold relative increased risk of DKA using one of the new SGLT2 inhibitors. Diabetes educators should be alert to the increased risk and share this information with patients and providers who choose to utilize this medication. One of the challenges is that DKA in this population occurs with euglycemia, near normal or only slightly elevated blood glucose levels, making the diagnosis much more elusive as is typical of DKA to have significant hyperglycemia. A suggested mechanism for the increased DKA risk is the reducing in basal insulin, which may cause a failure to suppress lipolysis and ketogenesis even with glucose values within target range. Glucagon secretion is increased, which could also be a contributing factor. So we have a polling question. What are the common symptoms for DKA? Please vote. So what are the common symptoms for DKA? C is the correct answer: excessive thirst, frequent urination, and weight loss. So we as educators need to be very clear about the ways to prevent DKA, as it is both costly economically as well as physiologically. The role of glucose monitoring, frequency or SMBG, or utilization of CGM should be discussed. Establishing glycemic goals, sick day management, assuring adequate access to supplies and prescriptions, reviewing evidence of psychological depression, and identifying signs and symptoms of DKA and when to call for help. Diabetes educators play a critical role in helping individuals with type 1 diabetes to understand glucose targets, reasons for hyperglycemia, and how to manage diabetes during times of stress, and risks associated with poor management of hyperglycemia. Both physiological and economic costs should also be discussed. Glucose monitoring is the critical prevention piece. As glucose values rise above 250 milligrams per deciliter, so does the risk of developing DKA. Checking glucose via finger stick methods on a regular basis, prior to meals, before bed, and more frequently when sick, will identify an upward trend and alert the individual to be aware of potential DKA. Reviewing CGM data and setting alarms when glucose is greater than 250 will also alert to potential DKA risk. When symptoms do not match CGM readings, a finger stick should be done to validate the CGM reading. In educating individuals, parents, caregivers, and families, it is important to emphasize the role of using clinical measurements on a regular basis to determine hyperglycemia and to treat as recommended to reach target. The idea that one can feel hyperglycemia is a myth until it is often so high that moderate DKA is often present. And I think most of us have experienced that when someone says, I just don't check my glucose anymore because I know where I am. Establishing target glucose values can also be helpful. Although it is important to set targets that match the needs and abilities of the individual with diabetes, one should never be set for a target of greater than 200. Glucose post-meals and during illness may reach levels greater than 200 milligrams per deciliter, and circumstances should be reviewed and correctional insulin administered to reach targets of 80 to 180 to reduce risk. This important concept should be reviewed at every visit and rationale discussed for prevention. There are frequently times during the day, week, or month when glucose levels can reach values greater than 200 to 300 milligrams per deciliter. The concern is not so much the acute rise as the sustained hyperglycemia that can result in DKA. Unfortunately, without frequent glucose testing via finger stick or CGM, hyperglycemia can occur and without correction be sustained for hours and potentially days, raising the risk of DKA. Another topic that should be discussed to help prevent DKA is sick day management. Initially and at least yearly, sick day management should be reviewed with the individual, family, or caregiver. This should include advice to never completely stop insulin, even if food is not ingested. And I think we've heard that, unfortunately, a number of times with people. I wasn't eating, so I didn't think I needed insulin. Always consider the potential for DKA in pediatrics when vomiting occurs. Insulin doses usually need to be increased with illness, but potentially may need to be lowered in the cases of gastritis. Always have urine ketone sticks or preferably a ketone meter available with non-expired strips. The goal is less than 0.6 millimoles per liter. Stay hydrated. Consider additional insulin if trace ketones are present, and if moderate or large ketones are present, call an HCP immediately. When educating individuals, families, and caregivers about sick day management, consider providing a handout that will explain the recommendations of the HCP during illness. Have them keep the handout in a medicine cabinet or with diabetes supplies for easy access. And there are a couple of handouts that we have created that are available for you to share with patients that will be discussed at the end of this session. Adequate supplies can also be an issue and increase the risk for DKA. Trying to stretch insulin has been one of the documented causes of DKA. An inability to obtain glucose strips or sensors due to a cost or limited insurance allocation can also contribute to the risk of developing DKA. There has been widespread concern regarding the rising cost of insulin. Persons trying to stretch their insulin until the next insurance allocation or paycheck can precipitate DKA by giving insufficient insulin. As a diabetes educator, the question should be asked at visits if the individual and family with diabetes has adequate supplies. Insulin companies have patient assistance programs, and if the challenge is ongoing, changing insulin to a less expensive type, such as NPH and regular, may be an alternative. This would require education and support in understanding the different peaks, valleys, and duration of insulin actions during the transition. Looking to less expensive glucose strips may also be an option, or referring individuals to the industry coupons to reduce costs. Psychological stress can also have an impact. Identifying persons with signs, symptoms, or a history of depression may help to identify persons at risk of DKA. Noting medications that may contribute to DKA and reviewing the higher risk of those patients may also be a preventative strategy. Just knowing there are added risks due to psychological turmoil could potentially help to alert the individual and their HCP to review prevention strategies more frequently and to underline the importance of being alert to any signs or symptoms of DKA. What is specific about insulin pumps and DKA prevention? Although there is some data to support increased risks of DKA with insulin pump use, it is inconsistent and suggestive of operator error more commonly than pump malfunction. If the cannula or needle gets dislodged or blocked, glucose levels can rapidly increase as most persons using insulin pumps do not inject any long-acting insulin. Consistent and regular glucose monitoring, whether fingerstick or CGM, will identify rising glucose values, and corrective action should be taken to avoid DKA. Standards of care for insulin pump users include regular glucose checking via fingerstick or sensor. If the glucose starts to escalate after appropriate bolus insulin dosing, an improperly working cannula should be suspected. Glucose should be corrected using the insulin pump initially, and if glucose remains high or continues to escalate, an injection of insulin using a syringe should be delivered, followed by replacement of the infusion set. Diabetes educators and insulin pump trainers should emphasize this not only during the initial training, but during follow-up visits. Individuals often need to be reminded that this can occur at any time, including shortly after a new infusion set is placed, depending upon the conditions. And several times I've had patients who have inserted a new infusion set, said, but I have a new infusion set, but not realizing that that too could be kinked. So we're not going to go through this whole flow chart, but you can look it up with the reference provided. The challenge with DKA, I want you to recognize from this chart as a diabetes educator, is making sure you know when to refer. If urine ketones are moderate or large or greater than 3 millimoles per liter with blood ketones, and you get the phone call from the patient, it is time to send them to the emergency room. The treatment as noted above is complex and partially determined on their level of hydration. In addition, other factors are assessed, such as electrolytes, BUN, creatinine, venous pH every 2 to 4 hours, which cannot be assessed by you or the patient. To add to the complexity, 0.5 to 1% of DKA is linked to cerebral edema, which has a mortality rate of 21 to 24% in the U.S. DKA is serious and should be treated as such. Management protocol for specific to pediatric patients is available on the ISPAD Clinical Practice Consensus Guidelines, DKA and HHS by Woolsdorf et al. In 2018, which is an excellent reference. A diabetes educator care model to reduce pediatric admissions for DKA was done in Europe. 4 registered nurses received intensive training to qualify as diabetes educators. Each patient was allocated one specific educator, and I think this is key. So we're not looking at all 4, and you would call and get one of the 4. The patient would actually call and get the same educator at any phone call. The role of the educator was to engage the patient and families in ongoing education, group meetings, and review and update of the devices available to aid in diabetes management. DKA was reduced from 210 admits per 100 patients in 2009 to 1.8 admits per 100 patients in 2014. This study demonstrated that proper education and follow-up can have a significant impact on reducing the risk of children being admitted to the hospital in DKA. The research recommend that diabetes centers caring for pediatric patients with type 1 diabetes be equipped with highly trained diabetes educators who can help to empower children and families to better manage glucose and lessen the risk of developing DKA. there could be no better study to prove the benefits of well-trained diabetes educators in helping to prevent DKA in the pediatric population. Polling question number 2. What are included in the critical education points to reduce the risk of DKA? Excellent. The answer is both A and C. Review sick day management and discuss the role of glucose monitoring to potentially stave off DKA. The reason we don't use B is that there is very little evidence that discontinuing or utilizing insulin pump therapy increases the risk of DKA at this point in time. So educators beyond the clinic setting, how else can we help to prevent DKA on initial diagnosis? Diabetes educators can also be active in helping to support awareness of type 1 diabetes, including signs and symptoms, by being present and providing information through community health fairs, reaching out to schools to review signs and symptoms of diabetes with faculty and staff, provide talks to community and after-school programs, and reaching out to deliver talks to state and local meetings of healthcare providers in your area. The educator can play a major role in increasing community awareness to the signs and symptoms of type 1 diabetes, which can help to reduce the incidence of DKA on diagnosis. The more persons who have eyes out for children and adults exhibiting symptoms of diabetes, the more likely it will be that the diagnosis will be caught in the early stages prior to severe DKA. Now we're going to discuss hyperglycemic hyperosmolar state. HHS is a clinical condition with severe hyperglycemia and dehydration, often occurring in older people. Glucose is generally over 600 milligrams per deciliter. Serum osmolality greater than 320 millimoles per kilo. Serum ketones limited, and that's one of the big markers between DKA and HHS. And metabolic acidosis, usually they are normal. HHS is a clinical condition most commonly seen in persons with type 2 diabetes. It generally presents with severe hyperglycemia and dehydration. It is a severe and potentially fatal condition which has a higher mortality rate than DKA. Risk factors include insufficient insulin, once again, or oral medication in the environment of an illness, cerebral vascular event, MI, or trauma. An infectious disease is the precipitating cause in 30 to 60 events. An additional initial diagnosis in 7 to 17% of individuals with type 2 diabetes. Along with insulin deficiency, there is associated increase in circulating levels of glucagon, cortisol, growth hormone, and catecholamines. This results in increased insulin resistance and increased hepatic glucose production. The diagnosis is a plasma glucose over 600 milligrams per deciliter, plasma effective osmolality greater than 320 millimoles per kilogram, absence of significant ketoacidosis, and generally neurological signs are present due to decreased cerebral blood flow from severe dehydration. In order to evaluate HHS, a detailed history and physical exam are necessary. They help to determine the course of treatment and will also help to determine the etiology of the present condition. For example, does the individual need to be treated not only for severe hyperglycemia, but the underlying condition of trauma, cardiovascular, respiratory infection that initiated the sequence of events leading to the HHS? There is insufficient data to determine the true incidence of HHS. Based on some studies, close to 1% of all hospital admissions for diabetes are related to HHS. Most cases of HHS are seen in patients in their 5th and 6th decade of life. There is a disproportionately high number of African Americans, Native Americans, and Hispanics who are affected by HHS. There's speculation that HHS will become more common in children with the increased incidence of type 2 diabetes in this population. Why does this happen? As with DKA, there is insufficient insulin to manage the present condition. Inadequate insulin levels lead to a decrease in glucose utilization by the peripheral tissues and resultant hyperglycemia as glucose builds up in the bloodstream. Although glucose is in the bloodstream in high amounts, it is not getting into the peripheral tissues, which then signals the release of counterregulatory hormones driving the glucose values even higher. Counterregulatory hormones would include epinephrine, norepinephrine, cortisol, glucagon, and growth hormone, resulting in more gluconeogenesis. This drives up serum osmolality. The osmotic gradient increases and free water is drawn out from extravascular space. Water, electrolytes, and glucose are excreted in the urine, leading to moderate to severe dehydration. Production of ketone bodies is minimal because some insulin is still being produced, inhibiting ketogenesis, which is unlike that seen in DKA. Symptoms are often preceded by infection or by cardiovascular event and their symptoms. Clinic presentation includes polyuria, polydipsia, weakness, malaise, and lethargy. Decreased cerebral blood flow from dehydration can lead to focal neurological deficit, disturbance in visual acuity, delirium, and coma. Persons with HHS generally appear ill and can have tachycardia, orthostatic hypotension, and delayed capillary refill. Polling question number 3. What is the classic differential diagnosis between HHS over DKA? Thank you, and the majority of you got that. It's the absence of measurable ketones. Polyuria and polydipsia do not differentiate it because DKA has that as well as weakness and lethargy, and often a preceding illness. So the answer is C. So what can the educator do to reduce the risk of HHS? The role of glucose monitoring, frequency of SMBG or utilization of CGM, establishing glycemic goals, sick day management, assuring adequate access to supplies and prescriptions, and reviewing the evidence of mental status, depression, and potentially dementia. This last is the biggest difference, I think, with DKA. Certainly we have to look at mental status in patients with type 1 diabetes and the potential for DKA. However, dementia generally is not an issue as it frequently occurs in young adults and young people, but we have to really look at dementia in the older population and its possible contributing factor. So evaluating the potential for the onset of dementia, in general, the educational principles are the same for DKA and HHS. As most HHS is seen in the aging population, evaluation of challenges with forgetfulness, not taking medications in a timely manner, or forgetting insulin for meals, etc., is an important element of prevention. Although diabetes educators are not given the task of evaluating patients for dementia, Alzheimer's, or depression, throughout the education process and continuing evaluation, skip doses of medication, inability to remember to check glucose, frequent hyperglycemic crisis can all be noted and shared with the HCP. A discussion on home health or placement in an assisted living environment may be necessary, as independent living may potentially place the individual at risk with frequent missed doses of medication. And here's a case study. JC is a 76-year-old male patient with a history of type 2 diabetes for 35 years and consistent hyperglycemia. His A1C 1 year ago was 8.1% and is now 10.5%. He is on MDI along with metformin, 1,000 milligrams per day. His wife of 50 years died 6 months ago, and he has been struggling with cooking for himself. On further questioning, he admits that his wife had been giving him his insulin for the last few years, and he has had a hard time figuring out how much insulin to give. He also admits to frequently forgetting to give his insulin. JC has had reasonable diabetes management over the years with an A1C value from 7.5 to 8.5%. The escalation in his glucose values overall and admitting to forgetting his insulin places him at high risk for HHS. This situation should be followed up with sharing the information with the HCP and suggesting a visit with a medical social worker. He does have family close by, and they have accompanied him on several of his visits and could be asked to come back for a discussion on this concern. You decide not to share the information with the diabetes team, as JC is very independent and has been doing well for many years. He agrees to make a chart and check off when he delivers his insulin and will review it daily. 2 weeks after the visit, he is admitted to the hospital in HHS. He does survive the encounter, and plans are put in place to change his insulin regimen to fixed-dose insulin and to have his daughter call him daily to check up on his doses. A positive suggestion would be for JC to have a CGM with share capability. If his daughter or other care providers could see his trending data, they would be able to intervene early in the course of escalating glucose and reduce or eliminate the risk of another HHS encounter. As diabetes educators, we are on the front lines in helping to evaluate patients in regards to their ability to manage their diabetes. Sharing the information and making suggestions for support can make a big difference. Polling question number 4. What would have been a more appropriate initial action for the diabetes educator to help prevent HHS? Excellent. So the correct answer would be both A and C. Share the concerns with the HCP for sure, and talk with his family about potential oversight in this situation. So once again, reviewing the guidelines for HHS treatment, it's not an easy schema. HHS treatment is the same as that for DKA. Consultation with an endocrinology and an intensive care specialist are recommended. Since many patients present in coma, appropriate resuscitation with principles of airway, breathing, and circulation should be initiated. Aggressive hydration with isotonic fluid and electrolyte replacement, which generally helps reduce the amount of counterregulatory hormones produced. Keeping the glucose around 300 milligrams per deciliter initially to prevent cerebral edema is recommended. And once again, great guidelines and the reference stated at the bottom. So DKA and HHS summary. DKA and HHS are potentially lethal complications of severe hyperglycemia due to insufficient insulin availability. Prevention is the key, with initial and ongoing education. These conditions are often precipitated by an illness such as respiratory infection or a trauma such as an MI. They can also be caused by skipped insulin dosing, whether intentional, as in diabulimia, or unintentional, forgetfulness and dementia. Prevention and early identification are critical. The diabetes educator plays an important role in educating individuals, family, and caregivers on prevention, identifying individuals at high risk, collaborating with the diabetes team to minimize risks, identifying signs and symptoms and referring to an appropriate healthcare provider, and providing awareness to a larger community through health fairs, community presentations, and discussions with healthcare providers regarding signs, symptoms, and risks. So I have a list of references here. So we are now open for questions.
Great, thank you, Carla. So we've already got a number of questions in, but as a reminder, if you do have a question that you'd like to ask, you can type it into the Q&A box. So let's jump right in. Carla, the first question we have says, is euglycemic DKA present with SGLT2 inhibitors due to increased dehydration?
That can contribute for sure, yes. It's not the sole reason, but it is a contributing factor. So people at high risk using SGLT2s would be in a situation where they might become dehydrated. We were talking about this the other day with some colleagues. For example, someone that's running a marathon. That would be a very poor choice of a drug, and they can stop using it. If they're using it most of the time, they can stop using it prior to doing that. That would be kind of an extreme example. That would be an example, though. Yeah.
Great, thank you. The next question we have says, in a clinic setting, what symptoms would prompt sending a patient to the ER? For DKA, I think it's referring to.
Well, any of the signs and symptoms. So number one, we could check a blood ketone meter. If you have one available, that would be one way to do it. Certainly much better than using urine ketones, which is kind of like the old glucose strip where we knew what happened 7 hours ago, right? So using a blood ketone meter, if they're having any nausea, vomiting, abdominal discomfort, vomiting in a child with hyperglycemia, any of those times, and some of those same symptoms in someone with that's taking SGLT2 but without the hyperglycemia.
Great, thank you. What is the risk of type 2 diabetes, or let me restart. What is the risk of a person with type 2 diabetes getting euglycemic DKA with an SGLT2 inhibitor?
I do not know the answer to that. I don't know the answer to that. DKA is very uncommon in type 2s, but we certainly see it. And it may, theoretically, it may be someone that's on insulin that has very little insulin production, even though they have historically had type 2 diabetes. But I've not seen that in the literature. Can't help you. Good question.
All right, thanks. How much are you seeing illicit drug use as a precursor for DKA with the younger population?
Personally, I've not seen that a lot, though certainly in the hospital in Montana, which I just left, we certainly saw some of that occurring, but I can't speak to specifics on exactly how often that happens. What I did see frequently historically is diabulimia. And it's hard to diagnose it, of course, because many of the teenage young ladies you're seeing severe and recurrent DKA, but is that the cause, or is there a familial reason? Is there lack of support at home? I mean, there's all these other factors, but diabulimia certainly seems like that could be one of the precipitating factors. But I haven't seen, once again, hard to tease out, I haven't seen a lot of illicit drug use in our population.
Great, thank you. What was the reference guidelines that you mentioned for pediatric DKA treatment?
It's under ISPAD, International Society of Pediatric and Adolescent Diabetes, and I believe it's available to the public, so you should be able to just Google that, and they should have guidance for you. Excellent document.
Wonderful. Please comment on the difference between CO2 and bicarbonate lab values. Our hospital uses CO2 values in diagnosis.
And they can use CO2 in diagnosis. And there are, I think the other point to all of that in those charts is that you will find that there are different criteria in different hospital settings, but they all follow the same flow. So they can use CO2. That is one of the options. It is.
Wonderful, thank you. Let's see. Our next question says, is keeping blood glucose around 200 milligrams per deciliter for DKA and 300 milligrams per deciliter for HHS only to reduce risk of cerebral edema, or are there other reasons? I thought the cerebral edema risk was related to rate of fall over 100 milligrams per deciliter per hour.
And I believe that's true in DKA. The reason for the difference in HHS versus DKA is HHS patients usually come in with a glucose over 600. So that would be the reason you would keep it higher than you would with a DKA patient. But you do see significant risk of cerebral edema with a rapid drop in glucose, and that's certainly not recommended. It really depends on what they come in with. Where is their blood sugar when they arrive?
All right, thank you, Carla. The next we have, it says, when I give sick day education to people with gastritis, for example, someone who has nausea and vomiting, I often suggest freezing apple juice to make ice chips to consume along with plain water ice chips. In addition, I suggest taking 10% of their total insulin dose to help slow down or stop the production of ketones when ketones are noted in the urine. Any thoughts on whether this is appropriate education for initial sick day management?
Yeah, I think that's good. You don't usually want to have them without any carbohydrate at all, for sure. So that sounds like a very reasonable approach. And the reason I didn't put any defined criteria for how to treat mild or moderate DKA is because each team seems to have their own protocol that they use, but that certainly would be very appropriate.
Okay, thank you. In type 2 diabetes, what symptoms and or lab values would you refer to the ER for concerns of HHS?
So I think it's more symptoms because we don't really have lab values other than if their glucose value has been over 400 and they're lethargic, have any kind of neurological symptoms, abdominal discomfort, any of those things, I would send them to the hospital. And I think the other piece to this is, nobody wants to go to the hospital. So we get people saying, well, I'm just going to do this at home, or I'm just going to, I've done this before, I know how to do it. No, they really do need to. If they have severe hyperglycemia and it's been high for some time, and they have any of the neurological symptoms, excessive thirst, any of those things, they need to be sent to in the emergency room.
Great, thank you. And right now we just have one more question in, and it's a two-parter. And it says, what's the mechanism of DKA with SGLT2 use? What causes the DKA with SGLT2 use?
So I think that there is some theory on what causes it, but it seems to be the insulin dose is much lower and it does not suppress lipolysis. So remember, lipolysis and making ketone bodies is part of the mechanism, of course, that causes the DKA. Another very interesting, we talked earlier about dehydration increasing risk. The other thing that increases risk is people on these severely low carbohydrate diets that are taking SGLT2s. So that's another time where you would see a real problem with SGLT2s and DKA. But the theory is that it is largely because it's not getting any suppression of lipolysis.
Great. Carla, thank you so much for being here today and presenting this important information. And I want to thank all of you for participating and attending today's webinar. We ask that you please complete the evaluation survey in order to provide us with your feedback so we can continue to improve our offerings. And you can find the link to that survey on the first page of your participant handouts, which was linked in the email you received with your login instructions. And you can find the copies of the slides there as well. This webinar was recorded and will be posted on our website, diabeteseducator.org. And you'll find it under the education drop-down and then go to webinars. And there you'll also find the patient tip sheets on the same topics that we discussed today that you can use in your practice with people with diabetes. So make sure you register for these upcoming webinars to stay up to date on all the latest in diabetes education. And if you missed an earlier webinar, you can check out our website to view our entire recorded webinar lineup. Thank you all. This concludes today's presentation.